We all have different ways of describing mental health or mental illness. But among my focus really is the black people, as I work in mental health. All communities, all tribes and ethnicities, we all experience mental illness. It is everywhere. But in our culture, we, black people, research has shown that, for example, 25% of black people will go and seek help compared to 40% of the white people. There we are. So I'll put it on. Right. Thank you. I put there that stigma. People of all cultures, like I said, black, white, Asians, we all do get mental illness. But ours is deep-rooted, way back before us. And some of the reasons the research and other studies have shown, for example, 25% of black people seek mental health treatment when needed, compared to 40% of white people. Stigma is one of the things, and that stigma is rooted way back in our history. There were times when people felt that black people were not so sophisticated to experience depression, to develop anxiety and other mental disorders. Consequently, this has spread to generations to come. And sometimes you see people, when they're depressed, they start telling them, I'm feeling tired, I'm just being tired, I'm just stressed, because they don't know the symptoms or they don't want to accept it because there's stigma around it. Who is going to tell you I have mental illness? You're not going to easily get somebody to tell you that or to admit that. It's such differences that has brought our problems. So let us take a look at some of the stuff in brief. There are a series of reasons why people develop mental illness. There is racism. And racism occurs in so many diverse ways. There are some people, especially I know somebody who wrote 350 job applications. Did law, was looking for a place for solicitor's training, 350. After that, he got so low, his self-esteem fell so low. He had a very good degree, he went to Warwick. But that's where her problem started. Also, there are high poverty rates, particularly among black people. And if you look at the studies, unemployment is higher among black people in this country. And anywhere you see where anywhere you see high incidence of poverty, there is high rate of mental illness. Research has proved that. If you also look into the prisons in this country, there are more black people in prison than there are whites. And no one goes to prison and comes out the way they went. And we have had a lot of people, they will be in prison where they are transferred to hospital, psychiatric hospital that is. So the incarceration of our people has a lot to do with, in fact it has caused a lot of mental illness among our people. Reduced access to healthcare and housing. Black people suffer the most when it comes to housing, when it comes to those things. And these affect a lot of people. It's not everybody who has that coping mechanism to deal with those challenges. And the sooner they start deteriorating, but some don't notice, they don't think they have mental illness, they just think they're stressed, they just think they're tired. And by the time you know it, a lot of damage has been done. And they mistrust black people have for psychiatric services. For that, you can't blame them. I started work in 1996 after leaving Hull University. Sometimes, some hospitals in London, when police are bringing a black person, when they arrest you in town, the sooner you start talking differently, they're not taking you somewhere where they could interview you, they're taking you to a psychiatric hospital. And by the time they get there, they have already told the ward that this person is violent. They describe you in such a way, by the time you get there, the type of medication that is waiting for you. When they give that to you, sometimes you'll be off for like 2-3 days. So this has resulted in a lot of ways where black people don't even want to associate with psychiatry. They don't want to even go to see their GPs and tell them this how they are feeling. And cultural factors. There are a lot of cultures amongst us where people think mental illness has to do with spirituality. It's the devil. They say, oh, let's take him to church, or let's take them to church. The pastor will pray for them. But meanwhile, that same pastor, when they fall ill, they go to the hospital. You know? So culture, stigma, have all contributed to our problems in mental illness. So I chose some few common types of mental illness which we'll look at. They are so common, but sometimes most of the symptoms are not common among our people. And by the time they actually get to know or feel that these symptoms is mental illness, the damage has been done. And that's why a lot of our people go through to psychiatric hospitals on section. Because A, they don't want to go, B, they don't think they have mental illness, and therefore they have to section them to take them to hospital. Now, we take a look at depression. Some of the common symptoms are like feeling of sadness and unhappiness. The mood just drops, you start feeling low, and sometimes you sit down and you start crying for no justified reason. But that's how you will feel. And there's a feeling of hopelessness. You think you've lost everything, what are you doing? There is that feeling of hopelessness. And you find no pleasure in anything, not enjoying the things that you used to enjoy before. And sometimes some people take to their bed. They isolate themselves from people, from their friends, from their families, because they don't have any motivation to keep in touch with anybody. They exclude themselves and put themselves in their own world. And because they are isolated, their motivation is low and they are confined to their rooms or their homes, their personal hygiene deteriorates. Some find it, I have seen in my time, I've seen people who will take 3 weeks to have a shower because they don't have the motivation. To get up from their bed to go to the bathroom is a chore. But that's some of the symptoms. And during that period, your self-esteem goes to the floor. It falls to the floor. And there's always that feeling of guilt, blaming yourself for things that rational people wouldn't. But that's part of the illness. But you wouldn't know. And there's the appetite drops. That's why sometimes you see some people, they lose so much weight when they're going through that period. You know, because you're not able to leave your bed, you're not motivated, your appetite is gone. Because you can't leave your room, you don't want to have anything to do with anybody, you're not going to be thinking about food. And during that period, sleep becomes, some will say, my sleep was messed up. But then it goes on to be like an insomnia. You'll be lying down, you're so tired, but you can't sleep. And that goes on day after day, night after night. It becomes like, it comes like its own package, sickness in its own self. And that's how sometimes you see GPs prescribing sleeping tablets, different types, so as to help improve that. And during that period, the concentration becomes so bad. Consequently, they find it difficult to make any rational decisions. Now, some of the common causes of that, sometimes people are so stressed, bereavement, relationship breakdown, loneliness, family history, alcohol, drugs, and other illness. So let's watch for those as symptoms for depression. I chose psychosis and drug-induced psychosis as well. Some of the common symptoms of that is hallucination, where people sit down, they talk to themselves, there's nobody, they see things that don't exist or nobody sees them except them. And their delusions, they lose touch with reality. They think they are king, they tell you, oh, well, I own that company, I am this. They tell you sit down and you wonder. I say, the woman say, my son is gone. You know? And then they become paranoid. Some of their own close relatives become their enemy. They brand them, they accuse them of treachery, accuse them of everything under the sun. But that's part of the illness. And they have trouble thinking clearly. There's no logical thinking. They withdraw socially and keep themselves away from the public, spending time on their own. And their self-care declines. The common causes, not by a single factor. Sometimes some people are genetically predisposed, very vulnerable. And some are environmental factors, like we said earlier. And some triggered by substance misuse. That is one of the commonest part of it. And then now, I have 5 minutes left, I'm going through this. We have schizophrenia and paranoia. These are the symptoms. These are some of the common symptoms. Hallucinations, like I said, delusions, muddled thoughts, disorganized thinking, losing interest. And these are some of the symptoms and some of the common causes that I put down there. And bipolar is also one of the commonest ones we're seeing now. And it is an extreme of two things. They are high, very high, full of energy, excited, happy, and they become sometimes so irritable, overexcited, and then it drops down to a depressive mode. This same person that was active, happy, and happy-going now becomes confined to their room. Their motivation is low. They're not looking after themselves. So these are the type of, I chose those ones so that we can try to recognize the symptoms. Because if you know the symptoms of something, and one of the things that is affecting our community is the fact that we don't go to hospital or to doctor to report things until the damage is really done. We don't accept that we are ill. You know, every research you come across, that's one of our problems they mention. If you start seeing things that you don't understand, go and see the doctor and ask. That way, every early diagnosis will help you cure or heal the situation. But if you allow the situation to continue for so long, the damage would have been done by the time you get to hospital where you want treatment. So let us try and either keep our eyes open, talk to our family members, our friends. There are situations that we don't know about. Let's go and ask our doctors. Thank you. Now, if you have any questions, let's talk. Yeah, go ahead. Do you want a microphone?
Thank you very much for a very informative talk. I should disclose that I actually run a mental health service at the moment. So much around the symptoms that you described are very much akin to what my residents have. Certainly, I don't have any black residents though, but what I would say from discussions I've heard in the past, the prevalence of black men in particular in mental health hospitals is incredibly high. They're off the charts. And there is, I've been told, research being done in terms of a language that is being developed that is culturally appropriate for specifically black men. And the mental health model as it currently stands is really not geared around the language that black men speak or the symptoms that they experience when entering the mental health arena. And the fact is that they're often misunderstood, which is often why they're given psychotropic medication and drugged up to the hilt, which again causes them to have behaviour. It's a constant cycle. They come off the drugs, they demonstrate resistance, they increase the drugs, they taper them off the medication, the symptoms reappear, and they try to reintegrate them into society, that they've become so fearful and mistrustful of the system, and so the system goes on. What's being done about that?
At the moment, we have moved on from where we were before in terms of mental health. There's a lot of policies now which give families and patients or service users the right to even say, well, before it's the authorities that determine what medication you have, and some medications have colossal side effects, and you go in for one problem, you come out with 2 or 3 or 4. Now, patients have the right to say, no, I don't want to be put on that medication. This is what I had when I did it. In fact, some hospitals now, I've seen patients say, well, no, I don't want to be taken to Park Royal. And that is respected. Before, that was not the case. So the changes are coming, slow though they are, but they are coming. And when we have our own people training and being part of that lawmaking, it helps us. Before, that was not the case. We were following. Now, in a lot of cases, we are there leading. We sit around the table. We make those decisions. So things are getting better. I'm not saying they are. It's a working process.
Okay.
Quick
Well,
question.
that's excellent news with which to almost end on. You've got a question,
I have.
Madeleine.
If I do it, no hand. Okay, so one of the things that I noticed, and I get even more worried about it now, I've been a coach and therapist for 25 years this October, and the first thing people would say to me is, do you need to tell my GP, is this going on my medical record? With the instances of more, let's say, joined up recording, digital recording, and having things in one place, and all of the things that get hacked, one of the things I'm concerned about for people is how do they know that when they sit down with, let's say, their GP or a specialist, that those records will not end up being passed on without their knowledge. So can you talk a little bit about consent with regards to sharing your personal mental health information?
Yeah. Thank you. Now, they have a summary record. That is to say, if you're in London, your records can be tracked down in Watford. But here is one thing that is happening now. I have in the last 1 year or so, I've been working for a new trust. The patient has the right to say, I don't want my records to be put as universal, if you like. That is to say, it can be accessed by any health authority. You have the right to say so. And equally so, when you go to your GP, one of the biggest fears we have, black people, is our record being accessed. Just like you rightly said, people go on to their GP, and the GPs will just send your record. But now you have a right to say, I don't want my record being passed on that summary care thing. You have the right to opt out. But that has to be explained to you, because you only make the decision if you know. You know, so that is one point we need to bear in mind. You have a right to opt out. Now, consent is more important and taken seriously, just like I said before. Patients now have the right to say, I don't want to be treated with that medication. I don't want to go to that particular hospital. And that's been respected. Certainly where I've been working, it's been respected now. Before, it wasn't the case. They want to treat you, and anywhere convenient for them, that's where you're going. And you had no choice. But now it is different. Things are improving. And I've been around from '96 to now, so I have seen how it started, and I have seen what it is now. There's a very high level of improvement, and things are getting better compared to where they were before.
Thank you.
not sure if it will extend that far. You might have to come forward.
Yes, I wonder if you can simplify section, because most people don't know what section is all about.
Right. When they say this person is on a section, it simply means the sections are a law, and it is the law that gives them the authority to keep you in hospital for either 28 days and for assessment, that is section 2. All that comes around when they come to meet you for to take you to hospital, they will give you the option to come voluntarily. When you agree, then there will be no need for you to be on section. But that is purely based on how your mental state has deteriorated, how your situation is. They will not just come and put you on section. If you say, okay, I will go, and I know I'm ill, and I know I need help, I'll go, they won't bother you with sectioning. But when once your condition is such that you need to be treated, you're safe to be treated in hospital, and you're refusing to go, and they know fully well by their clinical judgment and assessment that if they leave you out in the community, you deteriorate and you'll be a risk to yourself and to others, they will put you on section. The section is a law that gives them the right to take you to hospital for 28 days, and section 3, which is for treatment and goes beyond. All those sections can be renewed, but that is purely when your condition dictates for that.
Yeah, and I was just going to add, the section is under the Mental Health Act, all right? It's not anything else other than the Mental Health Act.
It just seems as if what you've just described, it takes so long. Some families are screaming for help, and that help just doesn't seem to come.
What do you mean?
Well, they want the section to be faster, the procedure to be faster, because they can see their loved one deteriorating, but nothing seems to be happening. No one comes forward, or the health authority doesn't come forward to say, we're going to do something. It just seems so sad.
Yeah. Can you give an example?
I understand what you mean. I understand what you mean. We as professionals as well, because what happens, the community mental health team that is working with this person would have assessed and referred to the AMP team, which is called the Approved Mental Health Professionals. They do the sectioning. Now, when they sometimes, I'm not saying in all cases, sometimes when they go through, they look at the risk that this person presents, then they would need the police. They would need the police to accompany them. That process takes longer, and that is what delays the whole process. Sometimes we have referred cases, we waited for 2-3 weeks. Meanwhile, the person is suffering. But the problem here is, the AMP team are ready to go and do the sectioning. But because of this person's risk history, they are not going to go without having the police with them, right? Sometimes they go if the risk is pretty low and everybody agrees that they can go on their own, they will. But also there is the general stuff, that is staff shortages. They have so many cases and there are few staffing. But most of the things that is currently delaying sectioning these days is the police that have to go with them. Because you have to wait for the police to give you their availability, and then you book the appointment to go.
Can you just say a little bit about the crisis team?
Right, the crisis team, they were set up to deal with just what it is, the crisis. Now, GPs can refer to the crisis team. The community mental health teams can refer to the crisis team. But as times have gone on, the demand for their services has exceeded the supply. That is to say, the staffing and stuff like that, and the places they have to go. The crisis team takes over. Say, for example, when they are discharging somebody from hospital, the crisis team nowadays will work with that person to get that person settled back in the community by monitoring their medication, visiting them, assessing their mental state. Because after a long spell of time in the hospital, people's coping system is different from where they were when they went into hospital. So when they come back, the crisis team settles them down and then now refers them back to the community mental health team. On the other hand, community mental health team staff visiting their clients or getting referrals, they will now, if they see this person is deteriorating, the crisis team can see patients in the community 3 or 4 times a day. The community mental health teams don't have that luxury. So they would now refer to the crisis team. The crisis team will now monitor the mental health of this particular patient or this individual. And they will now continue, they have psychiatrists, they have social workers, they have mental health nurses. They will now deal with the case until they reviewed the patient with their consultants to know or say this patient is now stable and far better than we took over. We can now refer that patient for long-term follow-up to the community mental health team, and then that patient will be transferred. But they're there to deal with crisis. They don't work long-term like community mental health teams. They will do 2-3 weeks. Very rarely they go to months. Very, very rarely. If a patient needs long-term care, they will transfer that patient to a community mental health team. But they deal with the crisis. And that crisis phase can be 2-3 weeks, and when they are sure, based on their clinical assessment and their reviews, if that person is stabilized on their medication, is stabilized with their cooperation with the community teams, then they would now transfer that one to a community mental health team for long-term treatment pattern.
It's just that my understanding of the crisis team, especially when I'm at work, if there's an emergency situation, I can ring the crisis team and talk to somebody. Sometimes they will talk to the person who's with me. And I thought that was like the first port of call for a member of the public if you need help, if you've got somebody who is in a mental health crisis.
Now they have the single point of access, PAR they call it. Every psychiatric team now, every community mental health team, every trust has that. The first spot you call there, they will carry out an assessment and review. Now, if that crisis where you are at that point of calling is severe, what they will do, they would make arrangement for you to go to A&E. Now, when you go to A&E, they have a psychiatric liaison team that will carry out an assessment there. They'll carry out an assessment there, and if you need to go into hospital, that is, if the patient needs to go into hospital, they can organize and facilitate that. Yes, you can call the crisis team, but they actually deal with direct referrals. But the SPA team now has taken that role that you're asking about. The SPA team deals with that now, and they can signpost that easily. You can call the crisis team, yes, but the crisis team really will take a referral.
Okay, thanks for that.
Okay, thanks. Oh. So do you want to come forward so you can...
So what's a little bit concerning about what you've said is about the fact that, so you mentioned the Mental Health Act. So do I understand right when I say that people have always had the right to say that people have always had the right to participate and make decisions about their health and their well-being? Or so you said that things are improving, but since when? Since when have things been improving? Because yeah, if people have always had the rights, but they've always been ignored too at the same time, even though they have the rights.
You see, rights come with responsibility. Yeah? Let's not forget that. When you have a right to participate in your care, you must be in position to do so, your mental state wise. Now, why they choose to make decisions for you, if A, they realize that you're not in a frame of mind, you're not mentally stable, mentally sound to make that decision for yourself. Or what your decision will be detrimental to your own very health, but you're not aware of that. So they will make that decision for you. If you have a relative or a carer or a next of kin that is available, and they would involve that person. But normally, most of the time what is happening is not that they're ignoring you, the individual, deliberately. No. It is because of the state of your mental health at the time. They realize, because they will have to do an assessment before they take you into any ward or any hospital. Now, based on that, they would know whether you're really fit to make decisions for yourself, or what you're actually making or suggesting or saying is good for you. But you wouldn't realize that because you're unwell at the time.
That's around your capacity.
Yes.
I understand, yeah. But sometimes there's an issue, isn't it, between someone's capacity and, yes, they do have capacity, and they might be explaining to a specialist, an expert, that no, I do not want that medication. I want a different type of medication, or I want a different kind of treatment. But they are being ignored.
Okay. I'll tell you one thing. I have seen situations, I entirely agree with you, because I've seen all those type of things. But also what you have to do is, even when they check a record, they know you did very well on this particular medication. Now switching that medication to something else will cause you more problem, will take you longer to get better. You know, it's very easy to go downhill mentally. Very easy, but it's extremely difficult to get you back to where you were. That's why sometimes they'll try different medications. Now what you have to think about is balancing the side effects to the achievement that you're going to get, how it's going to help you. Now, there's this saying that if it's not broken, don't fix it. If you recovered and did very well on this medication in the past, but you're experiencing these side effects, they would rather give you medication to counter that side effect, but treat you on that medication so that you get better and quicker than switching up, because when you switch that medication, it takes over 3 to 4 weeks for that medication to actually kick in. By then you're deteriorating. But you wouldn't know that, but you're going downhill and everybody is seeing that. That's how you stay in the hospital for longer. But if they start you on that medication that you did very well on, you're going to recover quicker than you going on a new medication which you've never had and you don't know the side effects of. Just because sometimes I've seen patients say, I want to be on that medication that this person had been on. You know, it does not mean because it worked for that man, it's going to work for you.
Yeah. I totally understand, thank you.
Yeah.
But sometimes people don't even want medication, do they? They want maybe talking therapy. And yeah.
Yes, there are stages of talking therapy. You get to a stage where you would understand what you're talking about. There's a stage you come into hospital, you don't even understand what you're saying yourself, never mind what other people are trying to tell you. And talking therapy goes deeper. It goes very deep. And you have to be in that psychological mindset for you to be able to participate into that particular therapy. And that's why it takes time to get you to that phase.
Okay. I hope your questions have been answered. Thank you very much for those of you that have brought these questions up. Really appreciate it. And thank you for your time and expertise. The segue into that